Hello, I'm Stephen Harris from the University of Sheffield. This talks about the potential impact of novel digital health technology to transform community services and the potential for addressing health workforce crisis. So, three really key problems with workforce in community services currently. Firstly, is the scarcity of qualified, experienced nurses. Now, this evaluation study that we're going to be talking about was set in palliative care and end-of-life services in community run by a hospice. And they're having particular problems with the scarcity of qualified experienced nurses. It's been exacerbated by various events recently by Brexit, and the number of vacancies contributed to staff burnout during the COVID pandemic. There are current ongoing problems in addressing the post-pandemic demand for health services, which is particularly severe in community services and is tending to worsen. And all of this is within the context of the NHS long-term plan to move more services out of acute facilities and into the community, which is seen as a solution for addressing the current high demand. The second workforce problem is the length and the resource intensiveness of training for community staff. So in order to work autonomously, they require a wealth of experience and training. There is, because of the demand on senior staff, there's quite often a lack of access to real-time medical and senior decision making and supervision for junior staff, which makes the training more difficult and more resource intensive. And quite a lot of time is spent shadowing senior colleagues, and after that shadowing, quite often carrying out joint visits and discussing cases at lengthy MDT meetings to maintain quality of service and to continue improving the capabilities of staff. The third key workforce issue is the inability to scale up services to meet demand. So we have this higher demand, and with the small pool of suitable recruits and high levels of competition for these senior qualified and experienced members of staff, there's difficulty in recruiting and retaining appropriate workforce. And the current organisational structures in community services tend to be fairly flat and inflexible, and there's limited scope for progression. So they're quite often just open to those experienced, well-qualified staff, and so that there's very little progression. So this demonstrates the existing model of community care. On the one side there, we've got just the community nurse going to visit a patient, and in the service we're looking at, they were managing 2, 3, probably maximum 4 visits per day. With the digitally supported model of community care, there's a delegated coordinator back at the hospice, and you have these more junior staff out in the community, and so they'll have like delegated tasks, and they'll log on when they get to the patient's home, and they'll have assessments and measurements and outcomes to record, and any particular activities that are required with the patient, but that the coordinator back at the hospice is keeping an eye on what's incoming from all of the staff in the community, and can see when there are concerns coming up or when there's any questions asked, and can actually straight away direct the person at the patient's home to, for instance, carry out further assessments or do medication checks or whatever. So we've got this kind of real-time senior support for all staff who are out doing the work in the community, and this is called the Encompass model, the Enhanced Community Palliative Support Services. So you can see here in this picture how the service works. So we have the coordinator here at the hospice. So we've got physicians, we've got supervising senior nurses, consultants, and the visits are already planned. You know what they're going to do, they're already scheduled, but they can send additional instructions. The nurse at the service user's house can update the patient's records, add reports and assessments, and check in and check out, look at vital signs, neurology, respiratory, cardiovascular issues, and what have you, and update the patient record, but also draw information back out of the patient record, and of course request assistance in real time from the supervising senior nurse or hospice physician or consultant. And they can see as well what's happening in terms of the information going into the platform. So the methods we used for the evaluation, it was a single site evaluation, so it was very much a real world evaluation of an implementation. It was theory driven, so we worked on developing, refining and testing theories through various mixed methods. And the evaluation was developmental, so formative and providing information to inform the development of the intervention, and summative. And we used pre-post comparisons early on and interrupted time series analysis later. And the methods we were using were observations, interviews, and routine data analysis, so various different types of routine data. Here's just a quick look at the intervention and quantitative data timeline. So we've got the reasonably early on, we did a ×1 and ×2 pre-post comparison. You see there was a little bit of implementation preparation time that went on, and then there was a phased introduction. So it was fully live around March 2016, but introduced in January 2016. Some of the preparation that was required to facilitate the new ways of working happened slightly before the technology went completely live. So a new multidisciplinary team meeting structure was developed, and systematic reporting of patient outcomes. So that started being recording on paper, so that when it moved over to electronic capture of patient outcomes and quality of life and quality of experience of the service, there were comparisons that we could do pre-post there as well. So so this is the pre-post analysis, the interrupted time series analysis, which was used longer periods of data, and the observations interviews carried on previous to during the implementation and preparation, and during the phased introduction until it was fully embedded in the service. The observations, we went on patient visits, we observed staff doing their paperwork using the computer to record data and so on, and write GP letters and all of the admin around that. We sat in on board rounds and multidisciplinary team meetings to pre-post implementation to get a feel for how that was changing. We began the initial theory development with meetings and informal discussions with key members of staff and key stakeholders. And then we carried out formal interviews with executive directors, administrators, managers, consultants, nurses, members of the rapid response team, and technicians in service. Had some key benefit assumptions that were in the initial program theory. So more appropriate hospital admissions through improved monitoring of vital signs, regular assessment of the family's ability to cope, improved care planning, more efficient working practices. So there's behind all of these key benefit assumptions, there was rationales that were backed up by interviews and informal discussions. Another key benefit assumption was reduced travel costs and more visits per day, streamlined multidisciplinary team meetings, remote support of the lower band staff, So having that capability really for remote supervision and delegation of tasks. So that's intended to reduce the number of senior nurse and medical face-to-face patient contacts that were required. And then more patients to be discharged to their home after a hospital episode. Here's a little look at the pre-post analysis of the home visits. So you see that all face-to-face visits reduced, indicating more efficient working, and also the benefits of real-time decision making, which turned out to be one of the key mechanisms really that were driving a lot of the outcomes. The consultant visits reduced, senior nurse visits reduced, with the introduction of Band 5 nursing staff that the hospice community palliative care service didn't have previously because they didn't have the ability to support them independently. So those visits increased from 0 to 208. And registrar, so junior doctors visits increased as well. And joint visits went down, so the registrars and Band 5 nurses were able to visit on their own without having to bring in more senior staff. And there was more service user reported outcomes. We were checking this just to see if quality of care was maintained during the change period, and actually increased positive responses, and there was a corresponding reduction in negative responses. So we see there that the response, yes, it's giving a lot of benefit, went up from 45.9 to 50.1, and the people who are saying no, the service isn't giving much benefit, went down from 4.1% to 2.6%. And the observed changes that we observed were statistically significant. We did some interrupted time series analyses, and as well realised that admissions to emergency departments decreased, and the admissions via the emergency departments as a percentage of all emergencies decreased. So at 17 months post-intervention, the level effect was a reduction of 76 cases per month of admissions to the emergency department. And as well, we're looking, so this was a pre-post assessment of were people receiving more appropriate hospital admissions, and you see there that there's an increase in admissions to the cancer specialist hospital and a decrease in the general hospital with emergency department admissions. And see here that there's a change in the emergency department admissions went down and general admissions went up. So yeah, demonstrating that people are actually being admitted to more appropriate services. And discharge destinations as well. So usual place of residence went up 3.2%, and people admitted to hospital bed or becoming a lodge patient went down by a similar amount. So in conclusion, the technology, the implementation of the technology and the way that it allowed the service to redesign the way that it delivered its services provided a number of benefits, and a lot of those were related to workforce. First of all, it allowed rapid development of staff competencies, and this wasn't something that was necessarily predicted as part of the initial program theory, but it turned out that staff learning on the job, they learned their competencies very, very quickly. And it made the training and induction much more efficient. The service is now able to grow its own workforce. There's additional career progression and role opportunities. So there's more flexibility. There's more gradients between the grades in the community service, and there's also the option to be one of the delegated coordinators back at base. The service was able to scale up the reach of its service. There was a reduced need for joint visits. Every visit became supervised by a senior nurse or a consultant. There was rapid real-time senior decision making, and this was one of the key things that led to greater efficiencies of the multidisciplinary team meetings, improved patient outcomes. There's the ability to be more flexible regarding changing planned visits once staff are out in the community. There's strong evidence of more appropriate care and improved service user experience as well. And we're currently evaluating this technology in community stroke rehabilitation services. There are also areas for further research, for instance, implementation in other settings, alternative integration models, a wider set of outcomes, for instance, across the whole range of health and social care landscapes, and some comprehensive economic impacts would be useful. We did some economic evaluation, but some more comprehensive work on that would be very much beneficial. Thanks very much. If you've got any questions or comments, just drop me a line. There's my email, and there's quite a bit further information there. There's links to some videos that talk about the technology and the implementation of it, and a couple of publications, a protocol paper and a paper of quantitative findings in BMJ, supportive and palliative care. Thank you very much. Bye for now.